I'm Dr. Anthony Kaveh, a Stanford and Harvard trained anesthesiologist and integrative medicine specialist. And recently, the news of Marco Tropper, who you see here, found dead last week at UC Berkeley in the Clark Kerr dorm. Now, I'm a little extra sensitive to this because I went to Berkeley for my undergrad. And this begs the question of why our medical system has been so incredibly inadequate at preventing these horrible and preventable deaths in our youth. Marco was only 19 years old. He was the son of a former CEO at YouTube. And this begs some very important questions in our life today. We'll do your Q&A at the end. But the first is, why are the youth dying? And more importantly, dying alone. So Marco is not alone. This here is a graph over the last couple of years of overdose deaths. And they are not appreciably going down. Maybe there's some good news at the far end there, but we still have a long way to go. And the question is, why? Well, it's not from any lack of money. This is in the state of California, one of the largest economies on the planet. UC Berkeley has a lot of resources to spend on mental health. I'm not thinking this is a money problem, nor is it a medication problem. We have all sorts of powerful drugs like Naloxone, brand name Narcan, help reverse the effects of opioids like fentanyl. It's not from the lack of medical devices that can help prevent sudden deaths in young people. I want to be clear, we have not gotten any pathological or forensic evidence back from Marco's death, though it likely was from either drug, sex, or rock and roll, which is the standard pediatrics mantra, because in the absence of any known cardiovascular conditions like hypertrophic cardiomyopathy, long QT syndrome, most of these deaths sadly involve either an accident from a physical trauma or from an overdose. Things like automated external defibrillators are in no shortage around UC Berkeley's campus. I know this because I went there. It's not a shortage of medical devices. It's not from a shortage of emergency technicians and 911 respondents. Some parts of California have way insanely long 911 response times. UC Berkeley's campus is not one of them. Nor is it really a concern of stigma, though this is a very charged topic. The San Francisco Bay Area has made a lot of strides towards reducing stigma around talking about mental health. This is not only important for our patients, but also for our loved ones, because it helps open the door to treatment, though, and this can be very charged, so please keep it respectful in the comments, there is a slippery slope. This isn't today's discussion, but I need to say that there's a difference between reducing stigma, which we're going to talk a lot about, and the corporate interests in reducing stigma, and the slippery slope to inviting victimization, sometimes for secondary gain. This is not about blaming anyone. It is about recognizing the roots of and the root causes of being stuck in addiction. Why my patients stay stuck. And more importantly, why there is such a loneliness epidemic. Because we're going to talk about the enormous failure that comes from Narcan being touted as the end-all be-all in so many political agendas in the lip service without addressing the loneliness that is the root cause. If you have ever felt lonely before, please feel vulnerable and share this in your comments. You'll find that you're not alone. You're not the only one. And we can't expect to address addiction without addressing loneliness. We're going to talk all about the connection here in a moment, but I want to be very clear that Narcan is the brand name, aka the expensive name, for Naloxone, which is the age-old opioid antagonist. So we actually use it in the operating room where I am here. Here's a vial of IV Naloxone. We use it all the time because if a patient is overdosed on medical-grade opioids, here's the synthetic one, fentanyl, then we need to reverse their overdose from the anesthesia, the opioid component of the anesthesia, with Naloxone. This is life-saving. This is powerful stuff. I am not discounting that at all. But, and this is a big but, overdose teams and squads that are deployed out there to help address the opioid epidemic and all of the legislation that our taxpayer dollars are funding, and it's not unreasonable in many cases, the costs have to be taken into account to understand what destigmatizing is really doing for our patients, if anything. So it costs about $22 to $60 per Narcan spray kit. Remember, I have IV naloxone. You can give naloxone, which is the generic name for Narcan, through IV, through an intramuscular shot, or a spray. What about oral naloxone? It's really not used because if you're overdosed, you can't really swallow the pill. The only times we use oral naloxone is for deterrence in things like Suboxone, which is the combination of buprenorphine and naloxone. And that's used for deterrent reasons, not to reduce an overdose or to reverse an overdose as an antidote. So these teams do cost tens of hundreds of millions of dollars a year in the United States, from the cost of the Narcan, the cost of training the personnel to use them safely and appropriately, and of course, the cost of the personnel. The cost of the Narcan alone is in the billions of dollars. This is not a small drug. Once again, powerful, life-saving drug. But I need to ask you this question, and I want to know what you think about this. Living and practicing medicine in the San Francisco Bay Area has given me this almost dogma that destigmatizing mental health means making Narcan use more acceptable, making it over the counter, making it cheaper. There's nothing wrong with making Narcan more accessible. I have no issue with this, and I hope that most of you watching also don't have issue with this. But reducing stigma is necessary but not sufficient to solve this problem. And naloxone certainly does not address the root causes that often come from trauma that we're going to talk about. I do want to take a quick break here to give a shout out to L. Phillips, Cornella. We'll talk about naloxone at the end in the live Q&A. M. Henderson, Pineapple, Dina. Very, very good to see you all. And we're going to talk about Narcan. And I'm not downplaying what you're saying, Dina. It is life-saving, but it's not addressing the root causes. The root cause is often in trauma. Paul, I want to give you a shout out for that super thanks. Very kind of you. So, by the way, if you're learning something new, do please hit that like button to share what you learned with others. You can join our private Q&As over Zoom by joining the exclusive access. The link is below. But we need to talk about the trauma and healing from it, which is the true long-term solution, often to loneliness and the addiction that accompanies it. Now, as you know, I hope, many traumas are classified, labeled, if you will, as little t or big T traumas. Big T traumas are these canonical adverse childhood experiences, which are absolutely horrible. Seeing a parent be beaten, going to prison, or being incarcerated, succumbing to drug abuse. There's no shortage of items on the capital T trauma list. Then there is the small t's, which, when accumulated over time, can certainly have significant physiologic and psychologic consequences, being bullied at school, etc. The trauma that we experience in childhood winds up our central nervous system. Yes, we can even see some examples of it here in the operating room when you're under anesthesia. I have lots of videos on that. It's a very real phenomenon. But what happens to lead to addiction is key, because there's three basic mechanisms that I'll share. Number one is that the more trauma we have, it's like building a dam higher and higher to suppress the water pressure from these negative experiences and memories that's building up on the other side of that dam. So as we build the dam higher and higher and higher, the water pressure isn't being relieved. It's just slowly growing as we try to repress and suppress it. Instead of releasing the water pressure by undoing the little water spigot at the other end, we're just building the dam higher. This is exhausting. It uses up your physical and psychological resources. No question about that. What happens when we get exhausted on top of all the traumas of life and our past? Does naloxone help that? No, often opioids will help that. I'm holding, once again, this is that medical grade fentanyl. Not the stuff that's being used in the streets, in the Tenderloin, not far from where I practice, but those are often used. And when we're consumed, we're not often seeking to be together, connected with others. We're isolating. Isolation and loneliness have a great overlap. Building the dam higher predisposes us to engaging in that loneliness, no question. Number two is the constant fight-flight response from someone who is suffering with PTSD is also exhausting. It's not just building the dam higher, but it's also being in that hyper-vigilant state, whether it's psychological to the point where we procrastinate because we don't want to engage at things that are unfamiliar, whether we call that escapism, label doesn't matter, but it is absolutely fatiguing. The more exhausted we get, are you more likely to hang out with friends or to go into seclusion, like where Marco was found, right? Loneliness. If there were people with naloxone to revive and resuscitate Marco, this would be a whole different story, but he was alone. These tools were not there. Number three is the fear of uncertainty. That is, if you know anyone from PTSD, you know that this is a major concern. When we fear the uncertain, we tend to go into reflexive coping mechanisms. Often, one of our key coping mechanisms is going to be to engage in isolation. If you overdose in isolation, no amount of naloxone is going to save you. No amount of Vivitrol, methadone. These aren't going to do any good if loneliness is at the core of your suffering and pain. And pushing an agenda for naloxone to be the end-all be-all isn't the solution. It's powerful. I use it in the operating room. And I want it to be more available, but not at the expense of shortchanging my patients from getting the care holistically that they deserve. And if you're out there and you know a friend or a loved one who's been suffering, please make sure that they have the naloxone available. But remember, if they're alone, like Marco was in his dorm room when he was found, no amount of naloxone will save the day. So with that said, I want to go into your Q&As. If you do learn something new, please hit that like button and share what you've learned with others, because your support helps me do this for you more often without ads. Courtney, can believing the doctors know better than you just to find out they don't cause medical PTSD? Yeah, that's called the betrayal of trust. Courtney, I'm so sorry to hear about that. Modern day traumas can include many things, but a repeated betrayal of trust is one of the most common I see in my patients. Vite says, I have CPTSD. I see a psychiatrist to handle it. I'm solitary most of my life. So I'm so sorry to hear about that, but I do want to point out that solitude is often a form of being alone that we seek out. Maybe you're meditating, maybe you're praying, maybe you're in the shower and just enjoying that time alone. Loneliness is not a choice as much as solitude is. So I hope that your alone time is from solitude and volition rather than it being thrust upon you. I had colon surgery and I have blood in my stool. I'm sorry, Cam, to hear that. I hope that you talk to your doctor about that. You should. I think childhood D caused a lot of my physical problems as an adult, heart problems, small strokes, PEs, etc. It's very possible, whether it's from medication side effects, whether it's from the cardiovascular effects of compounded traumas over time, they are real. And I have patients in the operating room or in my ketamine infusion clinic that I see these physical effects in all the time. And the good news is that if we can address the root causes of the trauma, often the body will heal itself in those physiological parameters. The blood pressure can go down, the sleep apnea can improve, etc. Oh, speaking of ketamine, Cindy says, I have tried ketamine treatments, EMDR. I feel like I've tried everything. If it wasn't going to work, I wouldn't leave my house. Well, Cindy, I admire your determination and grit, and I hope others can also be inspired. Life happens. As a former nurse and survivor of trauma, and now a certified clinical trauma support specialist, addiction is an excuse. Gosh, that's quite deep there. Addiction is often used incorrectly. I don't disagree with you if I'm understanding your comment correctly. This requires more discussion. I will say that it's often a symptom, and it should not be used as a diagnosis. Very deep insight there. You have the absolute best voice for an anesthesiologist. Thank you so much. Um, what is my solution for loneliness? Ash, it depends on the individual, but it's unlikely that you can address loneliness without addressing past traumas because of those three mechanisms I gave. And there are many more. Those are three common ones that I see where traumas lead to loneliness, often through that exhaustion, through that fatigue, through sapping us of our human being and pushing us into human doing. It's like trying to drive on ice. You turn the steering wheel, but your car isn't moving in the direction you want it to move in. If that's not addressed, feeling lonely is unlikely to be fully addressed in a sustainable way. Okay, doctor is not speaking of using opioids for real pain. However, patients with real pain end up as a true sufferers. Yes, pineapple water. Real pain, whether psychological or physical, can absolutely push someone towards opioids or cocaine or other drugs of abuse or loneliness or suicide. There's no question about that. But physical pain can certainly be a trigger for lifelong complications. No question about that, which is why chronic physical pain needs to be addressed. Absolutely, for its physical and psychological consequences. Elliot has heard of new inventions. Some gas stations install it looks like a smoke detector. It's an infrared heat sensor that detects breathing, then the pattern of respiratory depression that follows. Well, Elliot, I'm not specifically familiar with this technology, but it is important to recognize that addressing respiratory depression, which is what all opioids will cause at a high enough dose if they are agonists, is important to immediately identify and treat, but it might not address why they were there in the first place. I very much appreciate that update on the news there. Well, this is interesting. An unrelated question is, why is the HPV vaccine recommended for young people? Young people are more likely to contract HPV through their sexual practices. A couple other reasons, but we talked about the HPV vaccine in the context of cervical cancer a week or two ago, because cervical cancer rates are increasing, except in those who've been vaccinated. I don't want to debate the merits of vaccines, but I do want to raise awareness of the increasing number of deaths from cervical cancer in young people when we do have either a vaccine or pap smears, both of which can at least be somewhat effective in reducing the risk of developing cancer as we get older. Very good question. So many young have suddenly died after the shot. Well, Sandy, I don't want to debate the merits of vaccines. Yes, myocarditis is a risk. I actually know a couple of people who have contracted it. In the young, I will say that when we're looking at sudden deaths, it's often related to what I said, drug, sex, and rock and roll. Not from a judging place, but just most likely when you look at the stats, when someone comes to the ER or the OR, if something is broken, it's often not from an inborn genetic error if they've lived past age 20. It's often from something that's come into the body. Naloxone was not always available to those who needed it. Very true. Many good friends died because police I'm sorry to hear that, bushy-haired stranger. And this is why I am advocating for naloxone as part of the solution, not as the solution. Remember, destigmatizing mental health does not mean just putting more money in the pockets of Narcan producers. 1.44 billion over 5 years is a lot of money not going towards addressing a root cause. Right? One more time. A lot of money going towards not addressing a root cause. These are expensive band-aids, even if you come out alive. Very good questions. And can you talk about gabapentin for pain and if psych-ketamine will help pain? Well, very good question. Gabapentin can help certain kinds of pain, though recent data has really been conflicting on how much benefit it actually brings patients. Ketamine can help pain, both physical and psychological, depends heavily on the dose and the environment that it's used in. I have quite a few videos on this because I do provide ketamine to many patients suffering from pain, both physical and psychological. And it is very important that we address treating one to address the other. You can't treat physical pain without acknowledging the emotional pain that likely came from it and treating that pain as well, and vice versa. Well, thank you so much, Paul, for that super thanks. I use Kraton because I have no living family besides my grandparents, who I care for 24/7. They have dementia. I'm so sorry to hear that. When my burden ends, I will be completely alone. I'm sorry. I appreciate your caring for your grandparents, but they, I appreciate your vulnerability in sharing this, Paul. What I can say is that I admire how much you are holding in there to care for others. And that compassion, I'm sure, does not go unnoticed. If you believe in karma in some shape or form, I'm sure that is bringing you value and hope as well. The kratom, I need to just, yes, it is a known opioid agonist. It is naturally occurring, but it is often cut with illicit substances, which is why the FDA has issued so many warnings against its use in the United States. But Paul, I hope that you are careful in what you're doing, recognizing there are serious risks with kratom if it has not been tested. And a shout out to Margaret. Thank you for that kind super thanks. All right, I'm trying to keep up with as many questions as I can. Hello back. Do I drink coffee? No, I don't drink coffee. You caught me about doctors ghosting? Yeah, and then I realized that's like two in my new ones of them. So I brought it up to my care coordinator. Curly, I am happy that you're advocating for your physical health with doctors to make sure that you're not being ghosted and not being gaslit. And we'll do two more questions. I'm trying to keep up with your fantastic questions, everyone. And have I heard or read about new white clots? No, I haven't. I need to look that up. Can ketamine therapy help with diagnosed severe anxiety? Yes and no. Depends on what the root cause of the anxiety is. It's a very good question. I love how he reads out people's handles. Oh, David Howard. Well, David Hove, I hope I read your name correctly in your handle. Gabapentin was prescribed for my anxiety, did nothing, and I had horrible withdrawals. I didn't have nerve pain before getting onto it. Now I do. Well, Ramen Chef, I like your username there. I'm sorry to hear that. Another reason why medications should not be doled out indiscriminately, especially ones that affect our central nervous system. Gabapentin in particular is notorious for those side effects. I hope that you find healing from this new pain that's come on since you stopped it. And here, actually, on the other side, Margaret Lewis says gabapentin has shown to be most helpful for my back pain from an L1 compression fracture. Well, there you have it. You can hear both sides of the same concern, which is why anyone who's prescribing you gabapentin needs to be getting your full story to help best understand the risks, benefits, and whether that is appropriate for your risk tolerance. Well, Cairo Siri, I had explosions of pain in random parts of my body. I'm sorry to hear that. I hope that you do find doctors eventually that can help you. I see a lot of gabapentin comments here. And wow, a lot more gabapentin comments. Laura, so good to see you. Karen, I had a PE blood clot in 2020. I have issues with PTSD. My doctor doesn't help me. What can I do? Karen, if you've seen my videos on gaslighting, because what you're describing is a doctor who seems to be aware of your medical PTSD, yet is brushing it off, perhaps not acknowledging its consequence or its import. Just as a quick reminder, ensuring eye level, not someone towering over you, not being naked in a gown when they're talking to you, bringing a friend, writing notes down. These are powerful ways to help reduce the risk of gaslighting. If those fail, bringing an advocate in their room, maybe it's a nurse or someone else in a clinic, but you don't want to be one-on-one if there is someone in a position of power who is blowing off your legitimate concerns, especially around medical PTSD. Those are the strategies I talk about in my other videos that I recommend that if you are able to, can engage in, and especially if you have someone out there who can come to your appointment with you. It's harder to gaslight two people than one person. Heather, I'm so happy to hear about your positive experience with ketamine and NAD. JP Fitch, Does ketamine help quit smoking cigarettes? It can, but it has to be used appropriately. Ketamine can be a drug of addiction. Yet I also help many of my patients overcome addictions by addressing the root cause, using ketamine therapy holistically and mindfully. Uh, And hey, bro, James McCoy, thank you so much for the kind comment. Hey, if you're learning something new, please hit that like button, by the way. Consider joining the live Zooms that we can answer more of your questions on one-on-one. Why don't I drink coffee? Stimulants determine lifespan. Kimberly, I kind of don't need more stimulation in my life, I think. I hope that answers your question. We talked about this one already. Do I know about functional neurologic disorder? Joey Reardon, that's what you mean by FND? Yes. I have had several patients with it. It is one of the most, unfortunately, intriguing. I don't mean that as downplaying the condition, but it is a serious condition that exposes so much of your mind-body connection. I've had success in helping my patients with it, but it requires a holistic input. And I want to address Deuce's TV here. Thank you for that super thanks. I just underwent general anesthesia a few weeks ago. Now I have bradycardia when I'm used to only having tachycardia from anxiety and obesity. Well, Deuce's, I hope you speak with your doctor about that. You want to make sure you haven't developed a new heart block from a heart problem that may have happened during the perioperative period or during the time of surgery. I am really wishing you the best there, and I hope that you speak with your doctor as soon as you can about that, especially if you're losing consciousness or having any dizziness, vertigo, etc. Paul, thank you again. And keep nasal naloxone just to be safe. Well, I'm happy that you are recognizing the risks, and I appreciate your kind comments. So GPs are able to prescribe methadone, buprenorphine, Subutex for SUD and keep them out of juice bars. Well, bushy-haired stranger, depends on where you are, and not all GPs are comfortable prescribing even some of those. So that's a big question there. Now, only pharma questions. Alexandra X, we are talking about destigmatizing versus big pharma making money. And I'm so curious to know what your thoughts are about whether this destigmatizing mental health can actually, in some ways, worsen our ability to care for patients by distracting from the root cause and instead looking for, if you will, cheap solutions. Not that naloxone or Narcan is cheap, but if you will, easy solutions that rob at least my patients of the care that they deserve. Laura, idiopathic intracranial hypotension. That's a tough one. I have seen reversal of it if it's related to overweightness. I'm not saying that's you, but if it's related to hormonal issues, there are some ways to reverse this, but it is a case-by-case basis. I'm wishing you the best in your treatment. Do I support iboga? For those of you, have you guys heard of ibogaine? This is, let me know below if you've heard of ibogaine. Do I support the use for opioid addiction? Maybe one day. I've heard a lot of anecdotal evidence around this powerful, powerful psychedelic from the bark of that tree in North Africa. But it is also a very potent psychedelic with limited research, but quite possibly can be a game changer for opioid addiction one day. Do redheads need more anesthesia during surgery? Depends on the medication you're using. The sevoflurane that comes out of the ventilator behind me can sometimes have a higher dose requirement, only about 10%. Loaded question. We'll talk about it in another live as well. You are so welcome, Michael Brown. What about PEDS, Ash? I'm so curious what you want me to answer there. What do you suggest for someone on benzos daily for disabling CPTSD who also has severe chronic pain, including spinal degeneration and lupus? Well, Vite, I'm sorry to hear about all that. I can't just give a one-word answer other than advocate for an integrative medicine physician who will be able to holistically address all of these components, because lupus is unlikely independent. of the complex PTSD or the chronic pain. If you don't address all the components, you're just playing whack-a-mole with medications, and every time you whack one medication or one condition with a medication, you'll get side effects. Another mole will pop up that you'll have to whack with another medication. You'll get more side effects from it. I want to end with 3 more question and answers. Why? What question are you asking about Topamax? I'm not asking any questions about Topamax right now. Sorry. Brenda Stevens, does repeatedly having surgery with anesthesia cause dementia? Not as far as we know, but there are absolutely legitimate concerns around certain susceptible individuals receiving anesthesia and then developing cognitive impairment. It's a huge area of study and serious concern for my patients and don't get to go back home to how they were before surgery from effects of either the anesthesia, the surgery, or the underlying pathology or disease for which they're getting the surgery for. Hey, Sydney, thank you for the kind comments. Pain management for EDS outside of opioids, Ash. Well, you got to talk to your doctor. I will say that there's many trends in the United States around low-dose naltrexone being a very gentle baseline. But like I said, you can't address the physical pain without also addressing the psychological pain and vice versa. Paul, it is so kind of you with your super thanks. I appreciate that. Wow. I'm hoping that's the case one day. How do we stop surgeons from doing laminectomies and ruining lives? Well, Janice, it starts with, first of all, recognizing that not all laminectomies do that. Just like how not all gabapentin is bad, a lot of it is, but you saw some people commenting that it was actually very helpful. So it starts by advocating for yourself, recognizing the risks of failed back surgery syndrome, which are huge, and weighing that against the possible benefits of a laminectomy. Depends on so many variables. I'm so sorry if that's what's happened to you or a loved one. And I want to do one last answer to Tabitha. I don't think I've answered you before. Does having multiple surgeries for the same thing make you less immune? Make you less immune to what? The risks of having multiple surgeries in the same part of your body often include excessive bleeding because you're going to have more fiber tissue, more scar tissue, more blood vessels that might form within that fibrous tissue or around it, increasing the risk of bleeding. There might be more pain from adhesions that are going to now form again and again and again after repeated surgeries in the same place. The risk for chronic pain can also increase. But most importantly, if you're having surgery in the same part of your body repeatedly, it begs the question, what is going wrong in that part of your body that is requiring the multiple surgeries? And that alone might explain much of the excess risk of chronic pain, etc. Oh, I can't ignore this question. RSD and CRPS, you want to talk to your doctor about either stellate ganglion blocks or lumbar sympathetic blocks, about ketamine. I'm a little bit biased here because I do these treatments for my patients with CRPS or RSD, reflex sympathetic dystrophy. RSD was the old name for complex regional pain syndrome, CRPS. And Sammy Girl also recognizing that there is often a heavy psychological component, not always, but in many cases, because it's hard to live your life with debilitating chronic pain and not have it affect you psychologically. It can be so challenging. So I hope that you're able to find a pain specialist who is versed in these treatment methods and addressing you as a whole person, not just as a CRPS patient. Art Cam, so good to see you on here. Thank you for the kind comments. And with that being said, please remember that you have more power over your health than you've ever been told. I hope that you learned something new, and please let's not let Marco's tragic death go without a legacy of advocacy for ourselves and asking yourself, who can you advocate for amongst yourself, your friends, and your loved ones to hopefully not be alone and overdosed in a dorm of college or in your bedroom at home? The risk is real, and if we can't address the loneliness component to addiction, Narcan ain't going to do us any good.